Okay, guys, you ready for part 2 of the dysrhythmias? Here we have PACs, premature atrial contractions. If you look, you have PQRST, 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 and boop, there's another PQRST. Now, the difference between this and sinus arrhythmias is sinus arrhythmia is really not, the whole strip is a little off, right? They're not the same. If you march them out, they're not the same. With PACs, if you would count and you would get your piece of paper and mark here or mark here, or if you're a little bit more advanced and use your calipers, you would see this to here is the same. Okay, here to here is the same. But right here, your atrium decided to fire a little bit ahead of itself. Okay, wasn't sticking with the plan. And that's where your PAC. If we went back to the arrhythmia, you would see that if you marched them out, they weren't quite as uniform as this. Okay, P wave from another topic, atrial focus, occurs earlier in the cycle and definitely is a P wave. Okay, what causes it? Well, a little bit of everything. Stress, alcohol, illicit medications. I shouldn't say illicit medications, illicit drugs. Okay, decrease. Trying to think anything else that would really cause it. Sometimes people might feel it as a little beat in their heart. Okay, so what are we going to do? Well, we're going to tell them to stop the drugs, the alcohol, the stress, the smoking, anything that could possibly get that the urge, that other, to fire. We could check their electrolytes. So what electrolytes do you think would we check? Well, potassium's a good one to check, okay? Potassium, calcium, of course, and then, of course, the thyroid. I told you that thyroid's going to come back and hit us a couple of times. If a patient is feeling, and they feel like it's skipping beats, they're uncomfortable, so to speak, we can use low-dose beta blockers, okay? That can reduce the frequency of it happening. But like I said, it's going to be low dose, and it's only if the patient's really complaining about it. Okay, SVT. Now this is a kind of exciting thing to happen. So what SVT is paroxysmal supraventricular tachycardia. If you look, you see a hump QRS, hump QRS, hump QRS, okay? Hump QRS, and it goes on, and then all of a sudden, it kind of slows down and you get your PQRST, PQRST. This is all with your atrium, okay? Now, what we have to do is when we have somebody that has SVT, we actually have to get a 12 lead EKG to make sure that it's SVT and not something else, okay? The way you're going to know your SVT through via SVT and know that it's SVT and not sinus tachycardia is to think of this. Your T is swallowing up your P. Okay, you can't distinguish the T from the P at all. Okay, and that's what makes it different than sinus tachycardia. It is a very high rate. Okay, it's about 150 to 200 beats per minute. Everything's pretty much regular except the fact that it's going so fast. Okay. So, what are we going to do? We're going to make sure that the patient's stable. Okay. We're going to make sure that they are getting enough oxygen, their SpO2 isn't down, they have good blood pressure. Okay. We're going to find out, is it sinus tach or is it SVT? Sometimes you'll see in ATI or other questions it's PSVT, but really we always shorten it just to SVT. Okay. What other problems is the patient having? Do they have chest pain? A lot of patients complain about it coming out of their chest. Okay. Do they have a decrease in consciousness? Now, although the heart's all working, the P and the atrium and the ventricle are working, they're working really hard, which means, guess what? Their cardiac output is a little bit low, right? Remember what cardiac output equals? It's heart rate times stroke volume. Well, the stroke volume is going to be a little low on this end because it's not allowing the heart to fill, okay, especially the ventricles. shortness of breath. They could have hypotension also because of the fact of decreased cardiac output. Okay, so what do we do with SVT? Well, if it's stable, we're going to determine, if the patient's stable, we're going to determine whether it's a regular rhythm or an irregular rhythm. So basically sinus rhythm versus AFib or aflutter. If it's a regular rhythm, what we're going to do is we're going to first, we are going to do some vagal maneuvers. Remember that vagal nerve we were talking about? Well, we're going to have our patients to bear down. And if hopefully by bearing down, it'll reset that SA node. Or we can do a ice water into the face. Like take their head and put a bunch of ice water in a basin and stick their head into it. That's the most fun part. Or a carotid massage. So you can go to their carotid artery and you massage it. Okay. If none of those work, then what we can do is we can administer adenosine. Remember those 3 A's that I told you about? There's adenosine, amiodarone, or atropine. Well, this is adenosine. This stops the heart. It is actually kind of cool. Every time I see it, it's kind of really cool of how it works. But what we do is we will have a stopcock, and we would have 6 milligrams of adenosine, and we will push that adenosine in as fast as we possibly can, and then we're going to flip the stopcock, and then we're going to push normal saline in. Okay, what we want to do is for it to hit the heart fast. Okay, it dissipates in the peripheral areas, so we have to get it to go into the heart as fast as we can so that it could stop the heart. Now, on the outside, we're sitting there. We do this with a crash cart in place. We have pads on our patient. Okay, and what we're going to do is we're going to watch the monitor. We're going to push that 6 milligrams of adenosine as fast as we can. We're going to watch the monitor, and what's going to happen is that patient's actually going to go into, I just had a brain fluctuance. They're actually going to go into asystole for a couple seconds. Okay, usually I tell the patient that this is going to be kind of rough. They're not going to like the feeling that comes over them, but that they will, it's only going to last a couple of seconds and then it comes back. Okay. And it usually does. I think the one time it was 19 seconds that we pushed the adenosine and we sat there and waited and waited and waited and waited. And what happened? Well, 19 seconds later, it's kind of amusing because, at one point, one of the nurses says, can somebody give me gloves? Because we really thought we were going to start CPR and have to get them back going again. But 19 seconds was the longest that I ever saw. The patient doesn't feel uncomfortable. Okay, and effectively we stop the heart. We stop the heart just like you would pull a plug off of a computer. You know, your computer's not working well, so you unplug it and hopefully it will reset. Well, that's what we do with the adenosine. Now, we do 6, 12, 12. Some facilities are just doing 6 and 12. But right now at Good Sam, we do 6, 12, 12. If that doesn't work, then we can do chemical cardioversion. I'm sorry. Or we can do cardioversion with the patient, an electrical cardioversion. Okay. What we're going to tell them is to counsel them about avoiding triggers like caffeine, alcohol, pseudoephedrine, stress. We had one patient, every time she went over a bridge, she went to SVT. I actually worked with a CNA that every time she went drill duty, she was in the National Guard. Every weekend she went to drill duty and she ran. She ended up with SVT. I think it was a good ploy to get out of doing some running. Probably should have thought about that whenever I was taking gym. But anyway, she would go in SVT. So what happened to these patients is that they ended up going to St. Louis and get an ablation treatment. An ablation treatment basically looks at the areas of the heart that is misfiring, as you will, and we can basically cut off that nerve, okay, so that it is not able to fire anymore, okay? Okay, what is the difference between SVT and sinus tach? Well, with SVT, you don't see that P is following it. You can't see that P. Let's just face it. You can't see that P unless we take an EKG and really slow it down. Okay, so remember that when you have the SVT, we're worried about the first line of fire, so to speak, the first things we're going to do is the non-invasive ones, which is the carotid massage, the vagal maneuvers, and also putting the face in the water, the ice water. Okay, AFib. This is probably the one thing you're going to see a lot of, okay? AFib, if you look, all these little squiggly lines, okay? These squiggly lines are not P's, okay? Your P is not firing like it should. It's actually quivering, okay? So, and if you look, if you get your little piece of paper or your calipers and mark them off, well, you don't even have to do that. You can see they're not rhythm. And that's how you're going to tell this is a dysrhythmia, okay? Because the fact that there is no rhyme or reason with these. Well, if you think about it, it really makes sense. There's no P wave to actually fire to show the QRS. What's happening, and if I was in the video, I'd show you the fibrillation happening. What happens is the heart is just basically quivering. The atrium's quivering. But because of the ventricle, the left ventricle pushing out the blood, it's pushing out the blood through the rest of the heart, it is able to refill. And so it basically goes through the atrium down into the ventricle. Once the ventricle gets filled or feels like it's getting filled, then it contracts. And that goes with the right and left ventricle, okay? So it's filling at different times. It's basically like overflow is what's happening. They're not getting an impulse from the SA node to contract. They're getting the impulse because they're feeling filled, feeling filled, okay? But none of these are P waves. And then you see the QRS is not very wide at all, okay? What happens, or what you could happen, and what we see a lot of, is that a patient is AFib, and eventually the ventricle's like, hey, I'm not liking this. I'm not able to work like I'm supposed to work. I'm not getting filled like I should be filled. I'm done. And what that happens is they go into what we call AFib RVR, which is rapid ventricular response. Okay, when we're talking about rapid ventricular response, we're talking about a heart rate above 140. Okay, when that happens, we have to give medication to slow that heart rate down, okay? Because the person feels dizzy, their cardiac output's low, their blood pressure's low, generally low, okay? And this is what AFib with RVR is. And if you count it, it's pretty high, okay? Very uncomfortable for the patient, okay? Okay, so what can cause AFib? A whole lot of things, okay? Hypertension, CHF, it could be valve disease, pericarditis, congenital, COP, sleep apnea, alcohol, caffeine, electrical disturbances. It could be what we call a holiday heart. You said, the heck with this virus, I'm going down to Mexico to an all-inclusive resort down in Mexico and saying the heck with it. So while you're down there, you're taking a bunch of alcohol because, well, it is all-inclusive. And you're not used to drinking, okay? You're like a once-in-a-month type of person. You're going down there and you're drinking your heart's content because you don't want to deal with this virus or online learning or anything like that. So as you're down there, your heart's just not exactly used to it yet. So what happens? Your week's over, you drank your fill, you really made your money there, you know. Then you come home and you're trying to get back into the routine. You decide to come back to online learning. So what happens? Your heart's like, what the heck just happened? Okay. We call that holiday heart. Okay. I'm thinking that when you were drinking so much down in Mexico, you might have had some, I don't know, you overindulge and might have thrown up a few. When you throw up, you not only get rid of your potassium, but your magnesium goes right with you. Okay, so whenever you throw up or you have diarrhea, that's what happens. And Lord knows you might have had some of the water down there and had some traveler's diarrhea. That, just being low on your potassium, could cause you to go into AFib. So that's what we call a holiday heart, okay? So there's paroxysmal, which means it comes back in and out of sinus rhythm. Okay, persistent is greater than 7 days, and permanent means no matter what we've done, we cannot get you off of, get you out of AFib. Okay, so what are we going to do? Well, we're going to do an H&P. What's happening? When did it happen? Are they having shortness of breath, chest pain? Are they having edema? Is the AFib because of the fact that they're in heart failure? If unstable, we're going to cardiovert right away. Okay, when we're talking about unstable, that means their blood pressure is low, maybe loss of consciousness. Okay, we got to get them back. We got to get that heart right back. We're going to look at, we're going to order an echocardiogram, and we're going to see, is there a reason why they went to AFib? Could it be because of a valve? Could there be some damage in the heart that has caused the electrical current to basically misfire? Going to check that at TSH. We do that everything with the electrical. We're going to check the TSH. We're going to find out when all this started. Okay, if it started between the last 24 to 48 hours, they had a sudden onset. Maybe they just started feeling like crud. They couldn't get their breath. They were fatigued. Okay, we could possibly give them, cardiovert them right away. If they have been longer than 48 hours, we're not going to cardiovert them. Okay, the problem, and I'll get into the problem with the next slide. Well, maybe not the next slide. Okay, the goals of treatment: decreased ventricular response less than 100. Remember we talked a little bit about that AFib, RVR. RVR meaning above 140. What we're going to try to do is get them down to rate controlled. We're also going to try to convert them to sinus rhythm if possible. If we can, we're going to do it. And we're also going to try to, we're going to prevent strokes. I will explain the stroke part. Now, trust me on this. Wink, wink, blink, blink, asterisk, asterisk, asterisk. You will be asked what are the 3 goals of treatment, or what are 2 goals of treatment. Okay, this is the goal of treatment. We're going to try to convert them. We're going to decrease their ventricular response and a prevention of stroke. Some people think that maintaining the potassium, and I get their thinking. If the potassium's low, and because it's low, we went to AFib, then a goal should be to keep the potassium elevated. I don't want to say elevated, within normal limits. Nah, not too much of a goal, because a lot of times the fact that, yes, potassium was a little bit low, we're not going to really see, it's not just a goal for AFib, okay? Because if they went to AFib because of the fact that their potassium's low, just bringing up their potassium is not going to cause them to revert back to sinus rhythm. So that's why that's not necessarily a goal. But these 3 are, so please put that in your noggin. Okay, rate control. What we're going to do is we're going to use a calcium channel blocker. Ditellazem is an excellent calcium channel blocker for AFib. So, patient comes in and they are an AFib RVR. Okay, we could try a beta blocker to lower it a little bit. Okay, and we would do IV push. So we could do metoprolol as our first go-to. But generally when they're AFib RVR, we go right into the calcium channel blocker, ditellazem, otherwise known as cardizem. Now, what happens is with the cardizem, this calcium channel blocker can decrease your heart rate and your blood pressure. So when we hook them up to a calcium channel blocker like ditellazem, when we put them into an IV, okay, it's a continual IV, we're going to have to watch their blood pressure and their heart rate. So they're going to be on continuous vitals. Okay, we're going to check their vitals every 5 minutes until they're stable. Okay, but what could happen though is that, yes, we have put them on ditalism, the blood pressure is going too low, but their heart rate's not going low also. Okay, remember, we want to bring it down to below 100 beats per minute. So what we're going to do, if it happens that the ditalism isn't working, blood pressure is dropping, but not the heart rate, we're going to switch them to amiodarone. Okay, amiodarone, which is a great medication that helps the ventricular response. Okay, the calcium channel blocker, we're looking at atrial, but with amiodarone, it's kind of like, well, it's not we're not being successful with the atrium, so we're going to go for the ventricular response, and so we do the amio. The amio is an old medication, and it's great for rhythm. Okay, we're going to try with that's going to be the rhythm. We're going to try to control the rhythm with it. The only problem with amio is it's so hard. It has like a half-life of, I want to say, 60 days. It's a huge half-life. But it's a golden oldie. One thing we have to worry about with amio, and at this point we're all doing IV. The one thing about amio though is it's a vesicant. So if it does infiltrate into a person's arm, it's going to do a lot of damage. So we have to be very careful. We always use a really large vein, and we're going to use a 20. Okay, and then our digoxin. Digoxin we'll get into later. Digoxin is, let's just say, that is one of our last resorts if we can't get the rate controlled. There's a lot of problems with digoxin. We have to make sure the potassium's right. We have to make sure that they don't get digitoxicity. We have to make sure that the blood pressure or the heart rate is above 60. It's just one of those medications that it works, but because of so many different side effects, and plus it interacts with so many different medications, we try to do that as our last resort when it comes to rate control. Okay, conversion to sinus rhythm versus rate control. If onset is between 24 and 48 hours, we might try a cardioversion. We would use heparin around the procedure. We usually get a TEE, which is basically an ultrasound. We go down your throat and look at the backside of your heart to see if there is a thrombus. If unable to really figure out when this started, then we're going to put you on anticoagulation for 3 to 4 weeks, okay, which would be with Coumadin, and then bring you back to the hospital, and we'll do the conversion then. So, cardioversion synchronized with a QRS. Basically, what cardioversion is it identifies where the R wave is. Remember QRS? We're going to identify where the R wave is, and it's going to shock the patient at the R wave. Defibrillation, willy-nilly, it just shocks you. Okay, with cardioversion, we are definitely shocking on the R wave. We can also do chemical cardioversion with covert, which is the I want to say oldie but goodie, but we can use cardioversion, covert. Adenosine, I haven't seen it. We've tried it. I haven't been seeing it ever successful in cardioversion. And then we have digoxin, amiodarone. Any of these medications, even cardizem, what's interesting to watch is sometimes the patient does really well in these medications, and you'll get a call from telemetry stating that the patient looks like they're going to convert. And what basically happens is the heart rate slows down. It'll go down to 30, and the next time it pops up, it'll go down to 30, and then it'll stop for like 3 seconds. It'll have a pause, and then it'll come back to sinus rhythm. Really cool to see. I still think it's really cool to see. But anyway, so sometimes a patient can convert on their own with using digoxin, amiodarone, or tachycardia. Okay, so acute management. Okay, so let's talk about the stroke. Think about this. The heart, the atrium's just kind of like hanging out and quivering. This gives the possibility of blood to coagulate into that atrium. So what we have to do is we have to ensure that the patient doesn't stroke. When I said the paroxysmal, remember the paroxysmal where it goes in and out of sinus rhythm to AFib? That's the most dangerous to have. Because think about it. If you are, say you're in AFib for a couple of days, your heart or your blood has a chance to coagulate. Now all of a sudden you go into sinus rhythm. What's that atrium going to do? It's going to contract, and all that blood that's sitting in your atrium is going to go to your ventricle, from your ventricle to, well, depending on which one it is, but it could go to your lungs, it can go to your brain. Okay, so that's why it's important that we find out and we look to see if the patient has any clots, okay, in their atriums or ventricles. That's why we do the TEE. The way we're going to start with this is the heparin drip. Okay, when we first start the heparin drip, it's a weight-based, and we go via protocol how we're going to do it. But they'll have a bolus, and we will change the dose. It's an IV, continuous IV, and we will change the dosing with how the PTT is. Now with heparin, we're looking at APT, okay, or PTT. We're going to monitor that. So every 6 hours, we're going to draw a PTT and see where that heparin is. Okay, where's that blood? Every 6 hours. Once we get 2 therapeutic doses, after 6 hours, we can go to daily. Okay, so let's start this again. When a patient comes in to the ER and they're in AFib, we're going to start a heparin drip. The initial dose is based by weight, and then we're going to also use a bolus. It is continuous, a continuous IV. Okay, every 6 hours we're going to draw a PTT to see where the blood is, how thin that blood is. Okay, and the antidote for the heparin is protamine sulfate. Okay, after two therapeutic responses, 2 blood draws that show that the blood is adequately thinned, then we're going to go to daily. Now, whenever I first started with nursing, I remember if you had somebody that had a DVT or a blood clot, they were to stay in bed. You know, didn't want to get them up, didn't want the clot to break off and go into the brain or anything else. Things have changed, okay? What else has changed is not only do we do the heparin, but we also do the Lovenox injections. Lovenox injections it was kind of nice because the patient didn't have to be tied down to a IV pump. They could walk around. Okay, we found out that just because you have a DVT does not mean that part of it's gonna bust off and cause a stroke or a PE. I mean, I guess it could, and it has happened, but you know, you have more dire consequences staying in bed because you have a DVT or a blood clot than if you got up. Think about it. If you're laying in bed, you could get hospital-acquired pneumonia, bed sores, constipated. Okay, so they found that it's better for patients to get up and start walking around. With the Lovenox injection, that's weight-based also, and we're going to monitor the INR and platelets, but the injection is given twice a day, in the morning and at night. Okay, weight-based is for whenever somebody has a clot. Okay, we want their blood thin enough. Prophylactically, we generally give 40 milligrams twice a day. Okay, It's not weight-based for prophylactic reasons. So if you went into the hospital for a gallbladder or went into the hospital because you're having a baby and you're on bed rest, we would do prophylactically 40 milligrams a day. Now, why you start these two things, one of the two things, well, let me go back real quick. The greatest thing about Lovenox is we can send our patients home with the Lovenox injections. Obviously, with the heparin injections, we can't do that due to the fact that they're hooked up to an IV 24/7. So we do that. We're also going to start them on Coumadin. Okay, Coumadin is a long, gosh, it's an old medication also. But with Coumadin, we're looking at the INR. Okay, so we're going to start the heparin or the Lovenox at the same time as the Coumadin. The Coumadin takes a little bit longer. Well, it does take not a little bit longer. It can take days for the INR to become adequate. So the heparin and the Lovenox are a bridge until the Coumadin takes effect. Okay? And sometimes that's really hard for patients to understand. We're giving them 2 blood thinners. Oh my God, we're going to kill them. No, we're not going to kill them. What we're doing is the heparin works on some clotting factors, Coumadin on others. Okay, we're not killing them. We're just waiting for that Coumadin to get therapeutic so they can go home on a pill, or they can stay home on a pill. The problem with Coumadin, though, is that it does take a couple of days for it to get therapeutic, and there's dietary restrictions. Okay, dietary restrictions are anything that has vitamin K in it. So spinach, kale, mayonnaise, actually mayonnaise has vitamin K, are all things that we have to worry about with our patients with Coumadin. Okay, so the heparin and Lovenox are a bridge until the INR, and when we're talking about INR, it's 2 to 3, for the Coumadin INR to be therapeutic. But any of these medications are not considered clot busters. What happens, it does not help the blood clot. What it does, it thins the blood, so hopefully the blood can get around the clot, okay, which there's usually contributaries to get around the clot. But what it really does is it doesn't allow that clot to get any bigger. The body takes care of that clot, but the Coumadin and the heparin does not allow that clot to get any bigger, which is very important. Other medications we can use is Eliquis. Eliquis, we don't have to bridge with the heparin. Pradaxa, again, we don't have to bridge with the heparin, and Xarelto are the 3 that you will see most common. Unfortunately, the Eliquis, the Pradaxa, and Xarelto are really expensive. Coumadin is cheaper. It's a pain in the butt to go to the hospital and go to the Coumadin clinic. I'm sure you've seen, if you don't have Hulu or Netflix or anything like that, you've seen the commercials where Arnold Palmer is rather play golf than go to the Coumadin clinic. That's true, but like I said, the Coumadin is an oldie and goodie, and they so most people will go on Coumadin if they can't afford the Eliquis, or if their insurances don't cover it as much. Okay, Coumadin or warfarin, I guess I really went above. INR monitoring is what we're looking at. Antidotes, vitamin K, multi-drug interactions, dietary considerations, remember that vitamin K. So any green leafy vegetables, mayonnaise, there's a lot of things that you don't even consider that actually have vitamin K in it. And the goal is 2 to 3 is the INR goal. Okay, A-flutter. Okay, A-flutter. Okay, A-flutter. See these nice little sawtooth, as they call them, sawtooth? Those are actually peas. To tell the difference, because sometimes it's kind of difficult to tell the difference between A-fib and A-flutter, just because the sawtooth, so to speak, isn't very defined. is to look and take your calipers or your piece of paper and go between each of these QRSs, and you'll see that these QRSs are the same width apart. Okay, so remember with AFib, if you did that with AFib, it would not be the same. But here, if you go through the QRSs, they're going to be the same. Okay, occurs from the atrium, generating impulse at a rate of 250 to 400 beats per minute. Now, whenever you have a patient that has a flutter and they're on a continuous pulse or continuous pulse ox and the monitor showing, it's going to show really the QRS. So it's not going to show 250 to 400. It's going to show 60 or 80 because it's hitting on the QRS. The rhythm is regular, sawtooth pattern, and it's going to be the same as the AFib. Okay, it's going to be, we're going to try to control the rate of the pulses. We're also going to control the rate. We're going to try to convert them to sinus rhythm, and we're going to attempt not to let them have a stroke. Okay, and also I want to talk a little bit about the pulse ox. When you're taking a pulse ox and you're looking at somebody's rhythm, the pulse ox is like the worst thing you can do to know a patient's rate. Okay, because if you think about it, if they have any kind of peripheral disease, the heart rate's not going to get through to their fingers as well. Okay, so that's why we use the telemetry monitor. And if they're not on telemetry monitor, then we're going to use the apical pulse. You never trust your heart rate with the finger probe at all. Okay, I mean, if it's in the 80s and the patient's fine, okay, you know, we can say that it's within normal limits. But if it's showing, let's say 54, okay, it might be that the blood is not perfusing down to the fingertips. So that's when we have to do our clinical judgment and look at the patient, do an apical pulse, and really see if that's a true apical pulse or a true pulse. Okay, AV blocks. Now I know Tessa didn't go through the AV blocks. I have a video that I'm going to upload onto PowerPoint or to Blackboard to talk about AV blocks. But first degree block, if you look, PQRST, PQRST. Now, if you take this first degree block, you see how different it is from here to here. So from your P to your Q, it's a pretty far distance. If you get your sinus rhythm and you put it together, you're going to see that the sinus rhythm, it is firing a lot quicker. Okay. Anyway, what's happening is the SA node is firing. It's just taking a little bit of time to get down to the ventricles. Okay, so that's what's causing, but you still have your PQRS, PQRST, PQRST. It's just taking a little bit longer to get down there. Okay, usually they're asymptomatic. We really don't do anything. Okay, second degree is called Wenckebach. Okay, you see how there's a little bit, it takes a little bit for that P and QRS, and then look, this is a little bit longer, and this is even longer, and then you have a P and no QRS. And the poem goes, longer, longer drop, Wenckebach. Okay, so it's a little bit longer, a little bit longer, a little bit longer, and then there's your P and no QRS. That's Wenckebach. Okay, longer, longer drop, you got Wenckebach. Okay, this means it's taking a little bit of time to get there. It's taking a little bit longer to get there. Taking control a little bit more, and then all of a sudden the P is just not getting it back. The P is not getting it down, and the QRS is not firing. Okay, then it goes back. And you see, a little bit longer, longer, and then drop. And there's your Wenckebach because there's your P and no QRS. The video I have really explains it well, I feel anyway. Okay, there's another part of Wenckebach. Okay, classic Wenckebach, usually asymptomatic. can happen with angina, syncope. Okay, we can look at the medications the patient's on. Is there anything that's slowing conduction? So anything that is rate controlling, beta blockers, calcium channel blockers, possibly DIG or amiodarone. Okay, and what we're going to do is we're going to try to, if there's a reason it's happening, we're going to try to correct it. If not, we're going to end up putting a pacemaker in the patient. Okay, second degree, we see P, QRS, boy, those QRSs are wide. P, QRS, and then P, boom, nothing. Don't even know what's going to happen. Okay, this shows, okay, that the P isn't able to get down to the QRS. It's just it has a failure. Okay. Sometimes it can be, we only see this when patients have a syncopal episode. Okay. It's considered a left bundle branch block is the type 2. But you see there, P, QRS, no problem. P, boom, nothing. Okay. Anyway, depending on what's going on with the patient, how often this is happening, they're going to need to be paced. Okay, we're going to pace them, transcutaneously pace them. So we're going to put some pacer pads on them, and we're going to pace them until if we can't figure out the problem, then they're going to need a pacemaker. Okay, third degree block. Remember, if you have a 6-second strip, you take what they have and times it by 10. So this is 30. Okay, not really good. Okay, and this, the QRS is really not talking to the P's. Okay, you have a P, QRS, P, QRS, P, nothing. Okay, QRST. It's not any rhyme or reason. If you would put your little slip on QRS, you're going to see that your P waves are not equaling your QRS. Okay, when somebody's down to 30, they're going to need urgent pacing. Okay, we're going to have to figure out what's going to happen because they can't go this way for very long. If they do, they're going to end up going into V-Fib or V-Tach. Okay, I think I only saw one person that was talking when their heart rate was 31. You know, their cardiac output is very low at this point in time. Okay, here's the poem. If R is far from P, then you have first degree, longer drop, then you have Wenckebach. If some P's don't get through, then you have Mobitz 2. If P's and Q's don't agree, then you'll have third degree. I like my little video that I will have online. Okay, PVC. Then we have premature atrial. Well, now we're going into the ventricle problems. Okay, and PVC is the first thing that we're going to go with. PVC is basically, you have PQRST, 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 and boop, there goes a P. A PVC is wide and bizarre. It doesn't make any sense why it's there. Okay, and actually, usually they're a little bit more bizarre than that. Okay, then we go back into PQRST, 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 boop, there's another QRS. Okay, wide and bizarre QRSs. And the reason we have them are, actually you probably have one now. People who have them all the time, they don't even know they're having them. Okay, sometimes people do get symptomatic whenever they have a continual PVCs. Okay. One way we're going to do, if their patient's asymptomatic, we're not going to do anything. If they are symptomatic, then we're going to do beta blockers and possibly amiodarone. We're going to take away the lifestyle triggers. So alcohol, drugs, Red Bull, Monsters. Okay. We're going to make sure that they're cardiac. So if they are in heart failure, we're going to optimize their cardiac and pulmonary disease management. They can be unifocal or multifocal, coming from different areas. R&T phenomenon, and then bigeminy, trigeminy, and quadgeminy. Okay, that means that they happen in two PVCs or 3 PVCs or 4 PVCs. Okay. So we're going to, then our next ventricular is V-Tach. This is non-sustained V-Tach, which means it's less than, usually less than 12 beats of V-Tach, but it's more than 3. So look at it, and if you see, it's similar like PVCs. Okay, so here you have PQRST, PQRST, and then it's VVVV. So it's ventricle, ventricle, ventricle. It's usually a rate of 120 or more, lasting about 30 seconds. Some people feel it. They feel like a fluttering in their heart. They don't like the feeling. They come to the hospital or to the doctor's office and they get a Holter monitor on, or a event monitor, and hopefully while they have that on, their heart's going to go into a non-sustained V-Tach and capture it, and then we can give them medications to control that. Okay, need to exclude heart disease with echo and stress. Could give them amiodarone, fluticate, or sotalol, so anti-arrhythmia, and in presence of heart disease, it could be an increased risk of sudden death. Okay, so sustained ventral V-Tach. It's a bad rhythm to have, let's face it. You have low cardiac output, and what happens is there's minimal feeling time, and the atrium's not working like it should. It can be monomorphic or polymorphic. Polymorphic is also described as torsades de points. Ventricular rate is between 100 and 200 beats per minute, and the QRSs are wide and bizarre. If you look at this, look how wide the V-Tach, the V ventricles are, the QRS. Wide, 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 always cross. But if you look at it, it's about the same size, same width across. Okay, that's V-Tach. A patient can have V-Tach for a couple of seconds before they become unconscious and go into unstable V-Tach or also V-Fib. If you look at torsades, it's kind of like a birthday ribbon, those, that you twist for birthday parties. Party streamer, there it is, party streamer. But you see how it's high, then low, then high, then low. That is torsades. Okay, V-Tach causes, well, anything. CAD, digitoxicity, CHF, drugs. If it's stable, that means when a patient is stable, they have a pulse, we can give them amiodarone, lidocaine, something to that effect. Something that's going to affect the heart rhythm. We're looking to affect the rhythm. If it's torsades, we can give them magnesium. Okay, we're going to give them supportive care until the magnesium can actually get kicked in and help. With torsades, the only thing that could possibly stop torsades is the magnesium. Unstable, which means without a pulse, we're going to do CPR, defibrillate, and we're going to start ACL protocols. Okay, so if a patient is unstable, which means they have no pulse and they're V-Tach, we're going to start CPR and defibrillate. CPR is the #1 thing you're going to do, and you're going to see questions on a test. Patient telemetry call says the patient's in V-Tach. What's the first thing you're going to do? And I will tell you, you assess until it makes no sense. Okay, so instead of calling a code blue, you might have examples of telemetry calling you, saying the patient's in V-Tach. What do you do? Call a code, check on the patient, defibrillate, or grab the crash cart while you're going to check on your patient and assess them. Okay, because a lot of things can show V-Tach on the monitor, and that is not what's really happening. Okay, it could be junk on the monitor, it could be the patient moving. There's a lot of things, so you always check on your patient first. Okay, second question would be something like a patient is awake, or I'm sorry, telemetry calls, you walk into the patient's room, the patient is pulseless. What's the first thing you're going to do? A, start CPR. B, go get the crash cart. C, call the doctor, or 4D, you're going to defibrillate. Well, the first thing you're going to do is you're going to do CPR. CPR is always the first choice. Remember, and I love Karen when she says this, if there's one thing you can do for that patient, and then God takes you away from that patient and takes you to the heavens, what's the one thing you're going to do for that patient? In that aspect, the first thing you're going to do is CPR. Okay, the CPR is the only thing that's going to save that patient. So, then we go into V-Fib. And if you look, not really pretty. Remember how the V-Tach was pretty well the same height and width? Well, here you have small, wide, pretty wide, and then you have a small one in there. It's very disorganized. And that's exactly what's going on. With your AFib, it's disorganized, right? Because your heart, your atriums are quivering. Well, guess what? Now your ventricles are quivering, and that's what's causing this. There's no cardiac output. This is a low cardiac output. None. Okay? Death is imminent unless we do something. Okay? CPR, and then ACLS is instituted. Unstable V-Tach, we're going to do CPR, defib, vasopressin or epinephrine, amiodarone, lidocaine, or magnesium for torsades. Okay, if we were having a simulation, this is what we would focus on, is a patient that goes into a V-Tach or V-Fib. Okay, asystole or PEA is flatline. Pulse, also known as pulseless electrical activity. So sometimes you will have PEA, which is that you see a QRS kind of quivering. That's what we call pulseless electrical activity. The heart is still firing, but there is no pulse. Okay, we have to check the patient, confirm it in 2 leads. If they are asystole, we can give them CPR and epinephrine. Okay. A lot of times when you're watching medical dramas, Grey's Anatomy, which maybe I'll watch an episode this 8 weeks, Grey's Anatomy, ER, anything like that, a lot of times they see asystole and like, oh, call the priest. We have to pray for him. No, not necessarily. A patient can come back from asystole. Okay. It's critical to reverse the identified cause if you're able. And I've never seen it, but if there is a reason that it's happening, that they have asystole, we could pace them. Case in point, I had a patient, I was on the surgical unit, and I had a patient that was in for pancreatitis. She was a middle-aged woman that was mentally challenged. Anyway, what happened was pancreatitis, we do no food and antibiotics. Well, she had some medications that we wanted to give her, and she refused to take them. In fact, she said at one point, I'm going to eat the curtains if you don't give me some food. Can't do it. It's pancreatitis. Well, I had a patient come in. It was a hysterectomy. It was right around noontime, and I went into 304 for this patient that was a hysterectomy to check on her because they literally just brought her down the hall. I was coming out to get her a warm blanket, and the discharge nurse said, hey, Becky, telemetry just called and said that your patient in 307 is in heart rate in the 30s. I said, wow, that's crazy. Went down there, and oh yeah, she was a heart rate in the 30s. She was bluish around the mouth, obviously agonal breathing. That time we didn't have phones, so I looked out and looked at both ways, and I swear there was crickets. No one was in the hall. So I called for the nurse, the discharge nurse. I said, could you call the code? And she said, what? And I said, call the code. Went back in the room and started CPR. It was a well-directed code. People came in. They took over my CPR as I was crying because I thought I gave her a Colace and killed her. And we continued to do CPR. We worked on that lady for an hour and 20 minutes. Every time they would stop, they would say asystole, asystole, asystole. And I thought in my brain, because I wasn't a cardiac nurse at that point in time, that the patient was dead. I killed the patient with a docosahexaene colase. Okay. Well, once you know, we brought her back. She came back in sinus rhythm. A week and a half later, she walked out of our hospital. Okay. Don't know exactly what happened. They thought maybe she threw a clot of some sort. Not really sure. All I know is whenever they said asystole, I thought she was a dead woman. But nope, she walked out of the hospital, no problems whatsoever. So we did do a good job. And like I said, it was a really good code, considering that I was crying my little eyes out as I was doing compressions. Anyway, CPR, do you know your CPR guidelines? Like how fast do you do it? How many breaths per minute? When you're talking about acute care, I will tell you, you will not see anybody stop for the rescue breaths. Okay, we do it as fast as we can. Generally, it is thought that 140 compressions a minute is the sweet spot when it comes to compressions. Try doing 140 compressions a minute. It's rough. We don't stop for the breaths, the rescue breaths. Somebody is on the bag and gives those rescue breaths as we do CPR. Okay. When you're talking about acute care, we minimize the stopping. Okay. The times that we do not do compressions. So we do it, and I've only heard one person ever ask about a count, because generally we go until we can't go any further. And then usually at that 2-minute mark, when they do a rate check or a pulse check, then we step off and the next person goes. Okay. So in your clinicals, look out for that to see how that works. Okay. Pacemakers, almost done, guys. So pacemakers, they deliver an artificial stimulus to the heart. Okay, causes a depolarization and the contraction of the heart. We can use it for bradycardias, asystoles, and tachyarrhythmias. With the tachyarrhythmias, the heart goes fast and then goes slow. What happens is it kind of regulates the impulses to the heart. Okay, pacemaker is usually put in the left part of the heart. Well, it's left part of the heart, left side of the body, but I've seen them in the right side. I've seen them down by the abdomen for some strange reason. I've also seen them in the middle of the chest. So I think it's really whatever the cardiologist feels like doing. Okay, pacemaker, atrial pace. You see these little lines? I hope to heck you guys can see this pointer, but this is the electrical impulses of the pacemaker. Okay, so this is atrial pace. So it has that impulse, QRST, P, QRST, P, QRST. Okay, down here is the ventrically paced. So there's the little P's. They're really hard to see. And this one doesn't even look like it has a P. But you see where the QRS, it's firing right before the QRS. It sends the impulse right before the QRS. So that is considered ventrically paced. Some people are both atrially and ventrically paced. Okay, fixed means it fires at a constant rate. No matter what, it's going to fire. Okay, it'll fire at 60. Even if the regular SA node is taken over, it's still going to fire at 60. Demand senses the patient's rhythm. So if it goes below a certain amount, maybe 60, maybe 55, it fires if it feels that there's no activity. That's the only time it ever fires. Okay, we can have transcutaneous, which is the pads, like a defibrillator pads, but we can change our machine to pacemaker mode. Transvenous actually goes into through the venous, okay, through the veins into the heart. You'll see that with patients that have open heart surgery. Okay, they'll come back with transvenous pacemaker, and then implanted is your permanent. Again, can have single chamber or dual chamber pacemakers. Okay, special considerations. Just because you have a pacemaker, it's not gonna say that you're not gonna die from a cardiac arrest. Okay, a pacemaker does not affect it. Do not fire defibrillator over the pacemaker generator. So if you notice that somebody has a pacemaker, let me even say pacemaker or a portacath, you make sure that your pads are off those two implements. Okay. And pacemakers can cause AEDs to delay visor shock. What the AED does is it senses the impulse. So it'll tell you that no need to shock because it's sensing that impulse. But it really needs to be shocked. Okay. If a patient's in V-Tach, that pacemaker is still going to do that impulse. And that's what the AED is going to respond to. We need to override that. Okay. Implantable defibrillators. If a person is more apt to have V-Tach or V-Fib, so our patients that maybe go into unsustained V-Tachs or they are in heart failure, okay, we can give them an AICD, what we call an ICD, which is an implantable cardio defibrillator. And you can actually have dual. You can have a pacemaker and an ICD, or you could just have an ICD. I personally think that if you get a pacemaker, why not get an ICD? But somehow the insurance companies and federal government don't go with what I feel. Okay. Anyway, they're programmed at implantation to deliver the therapy at V-Tach or V-Fib. With them is that they might not even fail, they don't capture that it's a V-Tach or a V-Fib, or they are the leads broken, or the parameters aren't specific, okay, and we have to really dial those in, and it can continuous shocks when it's not supposed to. I can tell you a couple of stories of patients that came in. One guy was an alcoholic. His ICD kept on firing. He took his cell phone and put it up to his ear, and it fired, so it ruined his cell phone. So he was going across to his patient's or his neighbor's house to get for help, and I guess it was shocking him the whole way across, because as he was telling me the story, he was there. I was crawling to my neighbors, going, "Help! Help! Oh! Ow! Help! Help! Oh! Ow!" You know how hard it was not for me to laugh in his face when he was telling me. Anyway, he crawled over to his neighbor's house. It was like 2 o'clock in the morning. I guess he was drinking a little bit too much, and the neighbor didn't want to deal with him. Finally, after an hour of, knocking on the neighbor's door, the neighbor opened up, and there he was. So obviously he made it out all right, and I was talking to him in the hospital. So what we had to do is we had to readjust his ICD. Okay. The ICDs, yes, they're shock. If you touch somebody when they were getting shocked, would you get shocked? No. Okay, it's a low voltage. Think about it. When you're talking about a patient that is in V-Fib and we're shocking them at the bedside, we're talking 200 joules. When you're talking about inside, they're not going through that. The ICD doesn't have to go through adipose tissue and bone, okay, and skin to get that shock in there. So it's a lot smaller of a shock. I had one guy come in, and it was raining out, and he was saying, "Okay, boys, it's getting ready to shock," because people can actually feel that shock getting ready to generate. It's very uncomfortable for that to happen, but he was afraid that because they were wheeling him with a stretcher and it was raining, that they would all like kill over because of the shock, but it didn't happen. Okay. One thing to be note though is that even if a patient is dead, has passed away, the shock will continue to fire. Okay, so there's donut magnets on every crash cart, and we will put a donut over their chest to stop that ICD from firing. Okay, care of pacemakers. What we're going to do is assess for complications. This is for ICDs and pacemakers. Look for bleeding, pneumothorax, and pneumothorax means that we nicked the lung, and air, basically the lung has collapsed. It could be a small collapse or it could be the whole lung. Okay, and an infection. The patient with a pacemaker will have a sling and sloth, which means basically they look like they had rotator cuff surgery. Okay, and they're going to keep that on for a couple weeks. What we don't want them to do is raise their arm like they're getting a thing of salt from the top cupboard. Okay, they can move it, but we don't want to raise it up. What we want is that those leads to be implanted into their chest. Activity and limitations. Okay, and like I said, we don't want them to raise up. We don't want them to take a bath until that site is healed. Okay, and of course, we're going to do follow-up care. When a patient comes back, we're going to listen to the lungs because of that pneumothorax. We're also going to make sure they have a telemetry monitor on. We want to make sure that that pacemaker or ICD is working. And we're going to feel around that site. Okay, we're going to feel for that bleeding. If it starts feeling puffy, okay, edematous around that area, then we're going to assume that there's bleeding and we'll have to call the doctor. The patient is bed rest for 24 hours when they get a pacemaker and ICD. Okay, like I said, we want that to implantation. Okay, any questions, please write them down, and I'll answer them whenever we have whenever I have office hours. Okay, thank you very much, and I apologize it's a little long. Thank you.